very much for this very kind introduction. I haven't written hundreds of articles, only a lowly 85 or 90 and maybe 40 chapters, let's say. So, you know, it doesn't add up to some of those amazing prominent names in this department, like Ming Swan here, whom I just met, what a pleasure, and many others here, or the famous Louis Judd, I didn't know he was associated with here. But whenever I go to UCLA in the biomedical library and I get a book that I'm going to take home because I really want to read it, and I open it, there's an ex libris. It's a collection that's funded by Louis Judd. So I just think it's a great connection that he was the chairman here for so long. So thank you very much for this kind introduction. And I don't have a PowerPoint. I've just prepared some notes and would like to chat with you about some things I think about. Like Nico mentioned, I've been in the field. I started as a social worker in 1975. So that's, you know, whatever, how long that is, 39 or so years ago. There was no DSM-3 yet. I had never heard of the DSM for years. Didn't know that it even existed. Diagnosis was just an afterthought as far as we were concerned, something you did maybe afterwards. If you bothered to do it, nothing seemed to circulate or gravitate around the diagnosis of an individual. And so I think, like many of you, I've seen changes come and go. Because you received Thomas Insel here last week, I understand, I wanted to start with a couple of quotations from Thomas Insel, whom I'm sure has probably discussed them here in some way, and maybe to start with areas of agreement, areas, maybe things that we can agree about together, and then see if we can go from there, whether you agree with those or not. And those areas of agreement, this is from a paper that Insel published in 2009, I believe in Archives of General Psychiatry then. 4 parts to his comments that he made. The first one was, there's no evidence for reduced morbidity or mortality from any mental illness. He's looking at the assessment of biological psychiatry over the last few decades. He says there's no evidence for reduced morbidity, pain, suffering, distress, or mortality from any mental illness. From new psychiatric medications developed over the last 20 years, he says, in striking contrast, he says, to the steadily decreasing mortality rates of cardiovascular disease and stroke and so forth. Then he says, despite increases of 20 to 30% of people taking, following some kind of treatment, psychiatric treatment, he said there's been, quote, no change in the prevalence of mental illness between, and he talks over the last 2 decades, 1992, 2002, no change in the prevalence, and no evidence for decreased disability. And then he says, while more people are receiving treatment, fewer than half of those who receive treatment who are treated receive treatment for which there's any evidence base, whatever that means, evidence base. Everything's got some evidence base anyway, so I'm not sure what evidence base is really. And then third, he says, even when appropriate and evidence-based treatment is given, that is the latest medications, basically they don't offer the help that everyone thought they would or everyone promoted. And that's, he's talking here about that Katie study and the STEP-BD study and the STAR-D study, some of the largest studies, a couple of years following 1,500, 2,000 people, with the best available drug treatments for bipolar, the best available, the new atypicals and so forth, and perfenazine for schizophrenia or psychosis, and then the antidepressants for depression. And he says, interesting point, while psychosocial interventions have received far less marketing attention than pharmacological treatments, the results, he says again, are arguably more encouraging. Psychosocial interventions. And fourth, and that's really I think a very important point here that he makes, he admits, and I'm quoting him again, despite 5 decades of antipsychotic medication and deinstitutionalization, there is little evidence that the prospects for recovery have changed substantially in the past century. little evidence that the prospects for recovery after 5 decades of consistent use of antipsychotic medications have changed substantially. I don't think they've changed, not even substantially, they've just not changed if we look at the data better. And the data, he concludes, again I'm quoting, on prevalence, treatment, and mortality indicate that mental illness remains an urgent, unmet public health concern. So I'd like to ask you, and that could itself lead to a big discussion, but do you generally agree with Thomas Insell's, director of the NIMH's assessment of the state of progress of psychiatry? Do you agree with these statements? I know it's a loaded question, but I see some heads nodding and some, you want to know more, you want to see what else I'm going to say. So I'm going to assume for the record that you agree substantially with what Insell is saying. Is it a fair assumption? So I'll continue. I'm sorry.
A few parts, maybe.
A few parts.
Right.
Then, which parts might you not agree with?
Well, I think, for example, just substantial recovery from mental illness, right? One of the big challenges is there's really not any good way to, it's not measured well. So how do they know, I mean, so there's not much studies on recovery, and I did like a search of NIH-funded studies to see how many of them included recovery in their key terms. Very few, because there's not a good measure. If there's not a good measure, NIH doesn't fund it. Therefore, it's more unknown than anything else.
That's a very interesting comment. Thank you very much. I'm not sure if I'm supposed to repeat some of these comments or questions.
Actually, if you wouldn't mind summarizing, just because the audio may not carry
Thank you.
the tape.
So your comment was we don't have real good measures for recovery, so we may not know whether people are recovering or not. I think that's a great question about what's not studied, perhaps. How come we don't have a good measure of recovery? We have hundreds of measures, hundreds of drug effects. Hundreds, if not thousands. We don't have a good measure of recovery. Again, that to me speaks to where the system has been looking and where it's not been looking. So in essence, I think that whatever evidence we do have, I believe that Insell is right based on what he's looking at. And I don't know how he's defined recovery. That's a good question there. How is he defining it? But I take your point well, that it's not well studied. Although it's probably a very, very key direct concern to people in the system. Very direct concern to them. So if Insell may be substantially right in there, what does Insell suggest we do actually? He says we've basically failed to do what we wanted to do and what we've promised the American public and ourselves that we wanted to do. We haven't accomplished that. So what we need to do now is we need to go deeper and deeper into the biology of it all. Our DOC, research domain criteria. We need to get deeper into the DNA and into the circuits. We've changed. We don't talk about chemical problems anymore. They're electrical problems. The paradigm has been sort of dethroned. The chemical paradigm has sort of moved to the electrical. It's circuit problems, a bit like, I think, a bit as the sign on the building says. It's circuits. Today we speak of circuits. We don't speak of cells and membranes and as much as we used to. But we don't stop for a moment to say, well, what happened to that chemical paradigm? Was it disproved? Did we actually not find evidence for that? And what does that mean? So what I'm suggesting is going on, as Insell's promotion now exemplifies, is that we don't stop for a moment to acknowledge what exactly has gone on and what does it mean for the science of psychiatry. What does it mean for the testable assumptions, if any? Are they falsifiable? Have they been falsified? If so, what's next? What we see now is a continuation of the discourse that says this general biological approach, very mature now, it's not in its infancy as I believe we often hear, It's a mature 60-year effort. We now stop and acknowledge that didn't produce the expected benefits, and it may, Incel does not go into what harms it may have produced. And I'd like to discuss that a little later. We don't have clear accounting of the potential and real harms caused by the approach. So now we admit failure and we say, let's do more of the same, and even more, without pausing as to, is this a disease? Is this a brain disease? And that Incel does not stop to acknowledge that possibility, suggests it's not really a scientific enterprise we're here. We're not acknowledging that we have some testable propositions we have been working on for 60 years. And we have not practically, scientifically, theoretically come to anything that we can then use and use in practice, in clinical psychiatric practice. That we can take these insights that we have been pushing for these years and incorporate them into practice. Yet we're still going to continue and look for more of the same, just deeper, look more at circuits and cell assemblies and endophenotypes and SNPs and all those things that I read about now a lot. So that's one thing that I find is a kind of it's a divorce from reality. There's a discourse that continues and that does not quite acknowledge some of the scientific issues. And so I'd like to just put this out there a little bit. Despite nonetheless, and that when now we come into the larger system in which psychiatry and psychology and social work also are embedded in, is the fact that despite the disappointing effects of the remedies that we have been using, the remedies, which is that 20 to 40 psychoactive agents that are prescribed as the main professional response to all that distress and misbehavior that's going on. That number of drugs, that takes care. We spend $72 billion of the $239 billion that will be estimated, or is estimated to be spent in 2014 on all mental health and substance abuse services. That's $239 billion in the US. 72 billion of that is going for psychotropic drugs. That's a huge chunk of money in remedies that we recognize are not giving what we thought, according to our best studies, are giving now. So now also, I just hasten to add, now let me interject, that a lot of people appreciate and want to take prescribed psychoactive or not prescribed psychoactive drugs. We have many good ideas in psychology and the social sciences about why people might appreciate the psychoactive effects of psychiatric drugs. We have a lot of ideas about why people might use these effects in crises and get over them. We have lots of ideas about why people continue to take drugs even if they don't appreciate their effects. But those ideas have nothing to do at all with imputing any sort of dysfunction in the brains of people who either, quote, respond or don't respond to drugs. Those ideas are ideas actually first popularized by Norman Zinberg from Harvard Medical School in the 60s, who wrote about drug set and setting. Very kind of elegant model for explaining why people react the way they do to psychoactive drugs. You would never get any sense of these ideas from the thousands of clinical trials that are conducted every year testing the effectiveness of psychiatric drugs. You'd never get a sense of what is it about feeling sedated or feeling stimulated that might translate as to an improved score on a rating scale for depression. There's just no mention of any of that. But that subjective feeling of being sedated or stimulated or impaired in your perception or having problems with your movement or whatever, none of that somehow is incorporated into any design of a clinical trial, really. It's not connected to the experience of the person. It's not connected to we have no idea how really an SSRI might correlate in some people, a little margin, net improvement, might really correlate with improvement of depression or improvement of an eating disorder. We just don't know. Yet we have thousands of these trials that are done. And so again, the enterprise, of the clinical trial enterprise, appears also here again divorced from the reality of psychoactive drug prescribing and drug use. And that's also something that I think is problematic. To me, that's also not necessarily connected to what Michelle is saying, but it's an issue that requires some real grappling with. And I'd love to chat about that. And let me finally say that there's also this sort of shadow that looms over all of this reality, that the research in the field is divorced from what appears to be going on. One is simply that we just, like I mentioned very briefly earlier, we just don't have any clear accounting of what the drugs are in fact doing, both on an individual level and on a population basis. We just don't have any idea. We don't have any sense of, when I have nothing to do, I sort of estimate how many people in the US are actually taking a prescribed psychiatric medication. It's not so clear. We have numbers of prescriptions, we just get a sense of, well, what's the portion of the population? Well, simply speaking, just to give you a sense of, we got 430 million prescriptions of just 25 psychiatric drugs, according to IMS, in 2013 in the US. 430 million prescriptions, that's the top 25 drugs garnered 430 million prescriptions. So let's say, I don't know, 4 or 5 prescriptions a year, 1.5 drugs a person or so, so you come to about 70 million people. 70 million people. That's a huge, and that's only for the top 25 drugs. That doesn't include all the anticonvulsants and all kinds of other drugs, and the opiates and everything. So, we're probably looking at least 120 to 130 million people. And so, what's the population effect of this? I don't know. Does anyone know? I don't think we know that very well. We don't have any clear accounting of how many people are actually missing work because of a withdrawal effect. I don't know. No one knows. We know the costs of mental illness. We have dozens of the cost of schizophrenia, the cost of major depressive disorder, the cost of that, quality of life adjusted years and missed days at work. And we don't have any accounting of the cost of treatment. It's pretty amazing. As far as I know, my own search of the literature, which is of course imperfect, I'm totally fallible, like all of us, I hope, then as far as I know, I don't see any of this information out there. And so in a way, again, there's a kind of a divorce or a dark side to the enterprise that's just not present in the official discourse at all. And even in some of the discourses that you might be having with your patients, your own private talks with the patients. So I'll stop here just for now, and would love to hear any reactions to these propositions or comments I've made. Just anything that goes through your mind that, but you're on camera. How about if I start with this gentleman there in the center?
One of the points that you made was that we don't have a very good understanding of how psychiatric medications work. I think that's great because a lot of people outside the clinical realm sort of expect that they're prescribing this pill. Obviously, it works 100% of the time.
I'm sorry, they expect what? I didn't hear.
A lot of people outside the clinical realm see prescription as I have an issue, I'm getting this pill, this pill must work 100% of the time, and that's just not the case. But the lack of understanding of the functional mechanism is not unique to psychiatry. One could argue that the entire field of anesthesia is predicated on sort of, we've done this for X numbers of years and enough people haven't died for us to stop doing this, even though we have no idea how we initiate the lack of consciousness, the lack of memory formation, and then the resolution from the anesthetic state. Similarly, as you mentioned, opiate medications, the concept of pain is something that's completely unknown to us. There's this substance which somebody creatively titled substance P, and somehow that seems to be related to opiate receptors. So that idea that medications, we don't know how they work, should we really be prescribed them, is sort of a tenuous position.
Thank you. Thank you for this. 2 or 3 responses to what you're saying, if I may summarize it as that we don't know the mechanisms by which medication works doesn't mean that we should prescribe it or something like that, right? You know, and this is common in many areas of medicine where we don't have exact mechanisms, say, for how opiate will reduce pain or things like this, but yet we notice that it does. Well, first of all, I'm not making the case that because we don't understand it, we shouldn't prescribe it. I'm not making that case. Drugs are definitely something people want, number one. People want drugs. People appreciate drugs. Many people, not everyone, some people don't want them, don't appreciate them. This is just a fact of life. However, in these other fields, there is a little bit more, if I may say, humility about what is at work. What are the supposed mechanisms and how much of that is discussed in the media and how it's promoted as the essence of the scientific essence of the profession, which I understand to be in psychiatry. There is something wrong with your body. We don't know what it is yet. We in fact know it's there, but we don't know it. We can't show it. We are really hoping that it's very likely to be discovered tomorrow, the day after. And here's a drug that fixes that. For the time being. We're waiting for something better. We're looking for better targets. But we know there are targets there for these drugs to work. So somehow the drugs are these naturally guided missiles at the neural substrates of madness, mental illness. We don't know exactly how they get there. We don't know what these substrates are, but we know they're there. And now, and how do we know that this is all the way it works? Because we're looking at our clinical trials, which are immensely, you'll admit, rigged, artificial, completely, proof of effect. That many people have shown this sort of effect that we decide is the effect we're looking for, and only that effect, then this group of patients. And the clinical trial, as you know, has been critiqued by so many people in such compelling ways. I mean, basically, with proper controls, there are no effective psychiatric drugs in studies. The more you increase the controls, you increase the quality of the control group, the more the effect disappears. And it starts with an active placebo. The very first one is using an active placebo, which is not done in any study I know over the last 20 years in psychiatry. It's done routinely in neurology for pain medication. Routinely, active placebos are used to test pain medication. Routinely. It's never done in psychiatry for the last 2 decades as far as I know. So simple controls are absent. And the more you increase the controls, the effects disappear. So if I would take a well-designed study as my exemplar, then I would have to say, not only that the rationale for believing that the drugs are working and therefore that there are these targets that are being hit by the drug can be supported. So go back to the drawing board. The drugs don't work according to your best evidence. But that's not even the point I'm really making, even though it may be a fatal point, if you will. But the point I'm making is again, what is being said to patients? What is not being corrected when something is said, say, in the media about the latest study or so? That's this sort of more professional responsibility, what I would call, I saw a book recently called Psychiatry's Contract with Society. I think it's a couple of British authors who edited that book. It's a recent book, I'm forgetting who it is. And in that, and I looked throughout there to see what's the responsibility of a professional body to inform when they see disinformation or so. I I feel, with all due respect and great respect and admiration I have for people in this room, I feel that maybe there's not that responsibility to check disinformation is not exactly applied too much. And that's another part of it. The public figure of what is promoted by psychiatry, that the problems reside inside your body, your brain, your DNA, the genome, then that communication is just steadily put out and not corrected, even though the evidence seems to be there that it really stands in need of correction. So yes, sir.
What's the correction?
The correction is
What's the
we have not shown, we have not proved, the only thing we've replicated in this field is failure to replicate. That's really the correction, to state that simply. That we have not replicated what we are saying is going on in your brain, in your body, in your hormones. We've just not shown. So that the idea that the problem you suffer is in fact a result of some malfunction of your body is just not being shown to be true. Our own work has not shown it to be true. And true in the sense, in the Popperian sense, it has not survived any of the tests that we have, tested it with.
So we
So
should
that's-
say that psychiatric disorders are not a function of the brain.
As far as we know, as far as the evidence goes. As far as the evidence goes. And this is where, hopefully, we get some reactions so we can discuss more. Yes, Luz.
For me, my experience working with the Latino community and also at the different VA systems, one thing in which I see that there might be good is an integrated care where psychiatry works with psychologists, with medicine, and we see it, for example, in our PCT clinics at the VA, where we get a patient, psychology is the first door to the patient. You explain to them about medication. Many veterans are terrified, they have myths, they hate the side effects. They're in this taking, not taking medications, which end up putting them in a darker umbrella. We start doing an introduction, so then there's more open dialogue, so that by the time they get to the psychiatrist get the contextual picture, gets a patient that's a little bit more open to learning, and then after that, also the doctor comes in for the medical comorbidities that might be there. So if we start working more in alliance together, rather than as an independent parties, we might paint a bigger picture that it's not only what's wrong in your body, but what's wrong with your body because of the influences that are in the context, because of it's a whole system that we need to target.
Thank you. Sir.
Well, regarding the chemical electrical, I think that's a bit of a false dichotomy because intraneurally it's electrical, internally electrical. But when I started psychiatry as a Freudian psychoanalyst, my patient had OCD for 35 years. And when Prozac became available in 1986, and 3 weeks later, his OCD was dramatically improved. And my supervisor said, well, great, the therapy kicked in. After all these things. But then we went on to study this. So, high-dose SSRIs helped many people with OCD where nothing else did. And so we did PET scans of them, and we could tell from the PET scan changes those who had improved versus those that didn't. In your defense, therapy did the same thing, but the scans would say this person improved, this person didn't. And we've done this now with fMRI, with structural imaging. We can tell those who respond or not.
Yeah, thank you. Let me respond to your point first and then maybe comment on Luz, right? Luz. Everything works. I don't particularly believe that medications don't work. I think the search for evidence-based is a colossal mistake. Colossal mistake. Colossal waste of resources. But don't take my word for it. It's too limited. Take another talk. Where it's a blind alley, this idea that somehow there's some better evidence for what I'm supposed to do with my patient. And some cognitive collaboration or a bunch of meta-analyses are going to tell me what's really the best course of action. So I believe that almost everything works. There's no real science that we can understand to that yet. But yes, drugs have effects on the brain, kick in many mechanisms, including, self-healing, placebo, expectations, you name it. And also affect people. They create effects. And those effects may be useful to people. Whether there was a problem to begin with, that's a chemical, physical, or so problem, we don't know yet. But I think you'll agree with me that yes, we can document changes on the brain of drugs, and that they may correlate, those changes may be correlated to improvement. Correlation is not causation. Just want to remind us, correlation is not causation. It often looks like causation, but we need another step before we can talk about what's causing what. So I'm very open to the idea that drugs produce positive changes for some people, but maybe for other people with that same problem that you diagnose as OCD, they don't produce those effects. So we're back to where we start. Different interventions produce different results, maybe at different times, in different people, and in different eras. One could bring in the cultural, and I mean the large cultural, social, population health element, which is that certain eras create both their symptoms and their responses to distress. I think that's a sort of largely overlooked. There's that fellow, I forget the name, Alan someone, who's written a couple of books on how certain types of symptoms appear and reappear and disappear depending on certain eras. And how, in fact, your very questions in your interview will elicit certain kinds of symptoms. And people, veterans of the system, know exactly what it is they're expected to do and the symptoms are expected to produce to get this kind of intervention or help, or if they want hospitalization or whatever it is. There's a lot of this interaction on an individual level, on a group level, and on a society level that, again, is not carefully studied. And that's no fault of anyone. It's just that it's a complex reality that requires subtle attention to subtle things. And that's what a lot of this stuff is. It's very subtle what's going on. So I'm just saying it is subtle. It's all gray. It's not your brain. Just your brain. There's a gentleman here, and then who's had his hand up for a while.
Thanks. Are there any conditions of mental health that you do think might be an exception to the global perspective you have on the effects of psychiatry? And I'm thinking in particular of psychotic conditions, not so much neurotic conditions as we've been speaking about so far, whether it was called at one era of psychiatry organicity, or if it was called schizoaffective these days and so forth. Could you speak more towards those rather obvious conditions and perhaps the rather obvious effects that may have been borne out over the decades?
You're wondering whether I think that there are any conditions like maybe psychosis that don't fall into my overall view. And I'm not sure what that view, as you understand it, is the effect of medication or the organicity of the condition. Are there some things that we might grant to neurology, for example?
If I might follow up, it's somewhat well known, or at least I'm aware of some predominant research, and of course my own clinical observations, that my schizophrenic patients are less well when they're not on their medications.
Yeah.
There are some people who I won't even see unless they have an adjunctive care or conjunctive care with a psychiatrist in the community. And there's a reason for that. Whether it's a trade-off of symptoms is to be debated, or a trade-off of symptoms to side effects. If it comes between them thinking that they're the second coming of Christ and wearing, tinfoil hats versus feeling a bit glum and a bit sedated, I make that trade-off, but that's not the same as saying there's no effect.
I'm not sure. I hope I've not given the impression that I think there's no effect. There clearly are effects of the psychiatric drugs and the antipsychotic or neuroleptic or atypicals. I'm not sure what we're supposed to call them today, or second or third or fourth generation. What exactly? I'm sure, they obviously have effects. They're measurable effects in animals, in worms, in horses, in cats, in monkeys. We know, and they're pretty consistent effects across all these species. And all these psychoactive drugs have countless effects, well documented in animal studies, in healthy volunteer studies, and in studies with patients. So Drugs have effects. That's the point of the drugs. They have effects. Now, what your first part of your question, though, seemed to say, well, don't you think here that maybe that might suggest there's an organic basis to the condition? Is that what you're asking? Or you're asking that, I mean, I grant you, yeah, the drugs have effects. Whether the drugs are correcting something, or whether, whether that remains a point to be determined. You know, the jury is not in. Incel, I'm assuming, has access to some of that good research too. He's of the same opinion. He might not say it. That would be a pretty stunning admission. It's one thing to say this is not working, but to say we don't know what's there. It remains psychosis, as I sort of worded it to him at dinner last night, extreme mental states of unknown causes. That's the best we can say now. So, but the drugs have effects. How helpful they are, and what is behind relapse once you stop taking your medications requires, I'll be happy to get into that, but I think requires much more discussion, critical discussion, again, based on the drug studies and withdrawal of treatments in one group compared to, it's a lot of withdrawal effects are confused and confounded in the studies that allow us to say this, and clinical observation is, your point of view.
I thank you for following up, and I think a point worth delineating, because at one point it could sound perhaps like you were saying that overall psychotropics and so forth had minimal effects and minimal effect sizes.
Clinical trials looking at so-called efficacy, or if you will, even maybe effectiveness, if you want to stretch the notion, those trials consistently show small effect. The placebo effect in psychosis studies is about 30%. 30% just on placebo. So it's 80-85% in terms of how much of the placebo mimics the drug effect. It's about 80-85% for all the SSRI studies. And it's 30% for the antipsychotics. And those drugs with obviously visible effects, not like the SSRIs, which sometimes people say, I'm not sure if it's doing anything. And clinicians might not even notice them, but clinicians notice antipsychotic effects very quickly in the study. They know who's on, who's not on. So they have effects. Now, so there was a point that you had, and then...
Can I respond to your
if you'd like.
Your statement about insult? I think you're not stating what his point, which was that there are individual differences in the underlying biology that are not understood, such that some individuals respond very well to biological treatments, but we don't have the ability or the knowledge to target. And this was as a follow-up to your point, and I would just bring up an example. Clozapine.
Yeah.
And Ellen Sachs, if you've heard her speak or her story, is an example of someone who, when she's on her medicine, is in recovery and able to function as a professor of law, whereas when she goes off her medication, is in the hospital.
I agree with this anecdote, and we need more anecdotes of other stories. And I agree also with Incel's point that it's a plausible hypothesis within a general biological model that these individual differences that Zimberg would call drug set and setting, some funny combination of drug set, meaning expectations, whatever the person's history, including their biological variability or uniqueness, and setting, some unknown combination produces an effect. Incel is saying the same thing, except he's wording it. There's unique biological variability that we need to understand better, and it's probably going to be discovered in some way at that genomic level. And that's where we need to go. We need to be able to and then we can individually target treatments. Okay, yeah, sure. To me, it's, yeah, okay. Is it worth the effort and all of the research effort into that direction, given that all previous hypotheses about these underlying, they used to be called chemical imbalances, that's what I meant in terms of the metaphor, it's chemical imbalances, now it's circuit imbalance, which is just that. So that's what I meant, not so much the fundamental science behind it. So the metaphors keep changing in a way, and now it's unique biological variability that we need to target. Okay, yeah, sure. I think it's wonderful to be able to do this research, and we should do it. We've got to do it really rigorously, and we've got to realize we've been doing similar kinds of research, the bulk of the money, for 60 years. That's my point. Now, I have to take this melody here. Please.
So, what Dr. Insel's presentation on Thursday had me thinking about, and what you have me thinking about, is one of the fundamental aspects of public health is prevention, and that there are 3 stages of prevention. Primary, preventing the disease from occurring; secondary, preventing the progression of the disease in terms of morbidity and mortality; and the tertiary prevention, preventing that mortality. What we've been talking about today, and I think what the research that Dr. Insel suggests that we do, really all fuels the secondary and tertiary prevention. I'm curious what your thoughts are, or what you could imagine primary prevention being.
Thank you. Thank you. I was saying last night, I had dinner with a few residents, very, very thrilling experience for me. There's something that is completely ignored, I believe, in practice. Maybe not practice of psychiatry, but theory of psychiatry. And that's the noxious environment. I was saying that as a clinical practitioner, when I was a clinical practitioner, even I practiced 5 days a week, private or public, all I heard is noxious environment. That's all I heard from every single person. And so I asked my colleagues last night, I said, what does it take to studiously avoid theoretical discussions in psychiatry about noxious environments? It is studiously avoided, in my view. Humble, fallible view. I know we discuss it, we hear it, but it is not the subject of any systematic, even cataloging. So to me, prevention massively is about looking at the noxious environment. And we could look at how genetics interacts with this, and how, it would be wonderful. Once we take into account the massively dominant role of the environment in everything we do. And maybe there is a 3 to 4 to 10 to 15 to 20% role of genetics and biological variability, which is itself shaped by the environment, in my view, developmentally and in other ways. So that's the part. We don't do prevention in psychiatry. It's emergency medicine. It's that last thing that you need to do just to prevent a full-blown crisis. So that's where we're at. In other words, everything has constrained us to only act on that level, while, again, I'm sorry to repeat it, studiously avoiding the tales that we hear all the time. At least I've heard all the time. I saw my friend David Jacobs, clinical psychologist here in San Diego. I haven't seen him in a while. And we were just regaling ourselves with, this is all we hear all the time. All the time from everyone. And the worse off they are, the more it's been the environment, those who can say it. Those who are able to say it. The more impaired ones, the more disturbing ones, the more the environment has been terrible for them. So that's where prevention has got to go. And where prevention goes that way, I'm sorry, I see your hand. And where prevention goes that way to me is number one, and that's sort of a planning, large-scale population health perspective I bring to that, is income policies and family policies. Family policies, number one. Sort of longer maternity leaves. Whatever it is to make families more cohesive, a little more resilient. That, to me, would probably just knock off such a chunk of the distress we see later on. It seems so, the evidence seems so overwhelmingly how low socioeconomic status through the home environment, prenatal influences, the parental relations produces these negative adverse mental health outcomes. You can just practically see the line in large-scale studies, tested mechanisms of how this works. It's all out there. But if everything is in the brain, if everything can be fixed with only that better drug that identifies that biological variability, if 82% of the research funding is going there, of the public research funding, forget the private research funding, where that's going, I don't know where that's going. So then how do we begin on this? This is my objection, or this is how I respond to it. There's no prevention yet in this field. Or a little, too little. I don't know who else I'm supposed to take. What an awesome responsibility. Who hasn't spoken yet? Okay, Igor Grant is pointing.
No,
Sir.
Dr. Schuchter had a question.
Dr. Schuchter, please.
So there is an enormous amount of research in the role of stress in a stress diathesis model of mental illness, which a few people adhere to the notion that stress plays a role in precipitating changes in the brain and the
In a vulnerable individual.
in a vulnerable
In a
individual.
vulnerable individual. Another assumption that is not yet borne out.
And
It's
at the-
always the vulnerable individual,
And at,
that's
the same,
genetic.
and at the same time, frequently a great deal of effort goes to raise the perception of distress as a causal factor, as opposed to its artifactual nature. That is, that when people are ill, everything becomes stressful, and the illness itself distorts the experience in all spheres of personality functioning.
Yes.
And so relationships become deteriorated, work becomes impossible, perception of oneself becomes increasingly disturbed. And we look at these things as stressful, and they're really byproducts. It's not that individuals don't have some vulnerability, but that's...
You're saying the illness, you mean the psychiatric problems themselves?
The illness, yes. The
psychiatric illness.
The brain
Yeah,
disturbance causes distortions that magnifies life stresses.
This is a testable proposition and a plausible proposition. Perhaps, I mean, it's plausible enough that, it makes sense to test that. And the big piece of that is that brain dysfunction that you talk about. When you say the illness and ascribe to it an independent existence, the illness is the problems we're studying. To say that there's an illness that causes these problems, that the only way you've identified the illness is because of the problem.
Well, there's an interaction.
Of course.
It's not a
Yes.
unidimensional aspect.
But I'm sorry to belabor this point. Maybe I'm not expressing it well.
You're
But-
expressing it well. I'm presenting an opposing view.
Yes. I appreciate that. Thank you. I thought maybe I had been understood in terms of how I was expressing it. Thank you. Please.
Yes, I'd comment back to psychoanalysis, because all of us had psychoanalytic supervision 30 years ago when we started here. And I remember that we worried about the schizophrenogenic mother. I remember us coming out of that era, and the risk, what you're describing, I value what you're saying. I'm a social worker like you, but the risk for shaming, for triangulating against families. I'm very involved. 15 years been trying to help people get rid of the stigma of, and you're going to laugh, perhaps, addictive illness, because people are being incarcerated in the United States for addiction, in multiple hundreds of thousands of people are in prison right now. Our effort for 15 years has been to stop the saying these people have character disorders, or that parents were bad parents, or that there's risk for racism in somewhat of what you say. You could just say it's all, bad parenting, and then, it's all they didn't, they didn't they didn't do homework with their children at night. It's a high risk for what you're saying.
I think that, thank you so much for this. I think that the last 60 years of this, I guess for lack of a better word, medicalized approach that I'm trying to sketch, saying, has precisely exacerbated what you're talking about. And the evidence also bears it out. There is more use of coercion than ever before in the mental health system and outside the mental health system for those mentally ill in jails. They get even more coerced than the other prisoners in the jails. And psychiatry is more involved in coercion in the public system than ever before in the history. We have a number of figures that can show this. The percentage of involuntary hospitalizations now is about 66 to 70% of all psychiatric hospitalizations in the USA are involuntary. I want to talk about this a little bit because that's the part that also looms over all this, is the use of coercion as a helping profession. That's a big one. And it's generally best left undiscussed because it does raise certain passions. But the evidence on the attitudes and the desire to maintain social distance from people labeled mentally ill suggests very strongly that the more you adhere to a biogenetic model of the problem, the more you want to keep the distance and stigmatize the person. And that, again, is another thing that's contrary to what we hear, that the illness model removes stigma. I'm not sure that that can be supported in any way by the available evidence today. The belief that the person is affected with an inborn genetic, biochemical, or so problem may do more to stigmatize than that there might be some social or personal or other family responsibility for their behavior. So I'm not sure. I know that we had stigmatization before always. This is an ongoing issue in the field for thousands of years. But the medical model may have initially suggested that that's a solution to the stigma and the coercion is to adopt it. We've had it for 60 years again. We can look at the effects. And the jails are full of the diagnosed. Coercion is used as a fundamental, widespread primary measure, as a treatment, that it's studied as a treatment, not even as coercion. It's studied as coercion as treatment. So I'm not sure where this is going, but I feel that the evidence doesn't go in the direction you're suggesting. Sir, and then Nico.
Yeah, I have some questions about what you are referring to as the evidence. This reminds me of, Paul Neal had this famous article, Why I Don't Attend Case Conferences. And one of his points was about people, as his phrase was, shifting the standard of evidence depending on whose ox is being gored. And I feel like you're shifting the standard of evidence. For example, I'm thinking a simple example is like schizophrenia. Before you were saying that, like 70-80% of things are due to like environment, like low socioeconomic status, stress, that kind of thing. Whereas if we take schizophrenia as an example, first of all, people like Bruce Dowling and others have shown long ago that that's a social causation hypothesis, which versus the downward drift hypothesis, and it's the downward drift hypothesis which the evidence supported, not the social causation. But we also know from genetically informative data, with very solid evidence, that genetics, that schizophrenia is definitely genetically based, and it's not 20%. You flipped it around. It's
heritable?
Kind of
you mean it's heritable? You're talking about heritability, that statistic? Or you're talking genetically based, whatever that is? You're talking heritability quotient?
Now there's just been...
heritability is that formula that suggests to say that when you're comparing twins, identical twins and fraternal twins, that the difference between their concordance rates for a certain disease is going to be reflective of some heredity or some, variation in the population. But heritability, I can't get into heritability, but heritability is a wildly contested notion. Plus, it rests on the
I don't think it is.
It's a wildly contested notion in
you're
the field.
shifting the standard of evidence, and so the evidence you don't like, you dismiss.
Well, but I would love that. Then let's discuss heritability. And we have Ming Swami here. We could discuss heritability, and it's different from heredity. It's variation in the population. It's not. It's to explain what the variation in the population. It varies with populations. You can have things that are, like 2 eyes is not heritable. It's hereditary, it's inherited, but it's not a heritable issue. There's certain things that just don't fit with heritability. But the point is that when we're trying to find the markers for this idea of what is it genetically based, we have, for example, that study of last week in Nature, that big study that went around the world with 108 genome associations,
Right.
explaining what? 3.4% of the variance.
What about
3.4% of the variance.
what about the adoption studies where identical twins are adopted away so their environments are different? Doesn't change the risk.
Here you're on the shakiest ground here.
How so?
Well, you know, they all rest on an assumption called the equal environment assumption, which is that the environment of both of these sets of twins and are the identical twins, the non-identical twins, are identical. That's why we're able to say that any differences we see between them is due to genetics. And that idea, the equal environment assumption, is the bedrock of at least the twin study.
No, but
The adoption
studies
studies
have different
But there's how
environments.
many adoption studies have there been? 4, 5? From 3 Scandinavian countries? Maybe 1 in the US? 1972 by Heston? That's it.
Right, and they're consistent with the twin study
They're
data,
like
so it's a body
lines
of
in the
evidence.
sand with a widely stretched spectrum of what was schizophrenia. Was a schizophrenia spectrum? I mean, there's huge critiques of that, and I think that people constantly refer to the search for genes as saying the evidence from adoption, family, and twin studies is just so obvious. But then maybe that's one of the things we need to go back to and look at those studies to see whether the search is really justified based on that evidence. Now, you seem to accept it as being good. I don't know if I am here to actually provoke you to say, well, why don't you relook at that evidence? I suggest it is not good evidence, and I don't want to just shift. But on the issue of the ideas and the stigma, there is a nice review in Acta Psychiatrica Scandinavica, 2006, John Reed, Hasselman, Sayes, Davies, Prejudice and Schizophrenia, a review of the mental illness is like an illness, is an illness like any other approach. It's 2006, it's 10 years. It's a nice review. Reed and colleagues, 2006, Acta, nice review of all the studies looking at attitudes of people toward the mentally ill and their beliefs of what causes. And it's very much in the direction that I tried to summarize. But, sir. Oh, maybe Nico here, and then sir.
I want to come back to Caroline Stewart's point. I think it's such an interesting point looking at addiction. I think it's a sort of very interesting look at gamut of how psychiatrists or mental health providers have sort of labeled mental illness. And I want to provide an alternative to what you're saying. So in the past, we used to sort of say this is a characterological problem, defect of character. And then we moved on now to say it's a chemical imbalance in your brain that causes you to have this predisposition to do this. What about we sort of went one step farther and said, this is a normal reaction to drugs. Drugs are addictive. They provide those evolutionary pathways in our brain that made us want to have dopamine release. And it's really normal. You don't have an illness. You don't have a neurological problem. What you have is a normal reaction to anybody taking alcohol, meth, weed, whatever you want to use for a significant amount of time will have those things. Maybe you're going to have a little more, and you're going to be 3.4% variability between your genes and how much you might respond to this, and you might have a particular thing that happens to make you really, really like that. But what if we just hold those folks normal? I think that'd be a really sort of interesting look at the field. I also I was thinking earlier on, we were talking about antipsychotic, and I was thinking, who really, really sounds like David Cohen? It's Stephen Stahl, out of anybody, because Stephen Stahl says antipsychotic is such a misnomer, because it gives this implication that psychosis is too much dopamine in the brain, that somehow we've discovered that we have no basis for, and that antipsychotic are therefore the solution for that. And he actually is the first one to say this is so not based on evidence. Really, if we wanted, we could call them sedatives. Or really the best way is just to call them what they are. Anti-dopamine agent that happen to have an effect that we like to see in folks that behave in the way that we call schizophrenia. That is really what you should call them. And so it's really interesting that, out of anyone, Stephen Stahl really sounds like David Cohen today.
Stephen Stahl's books I read them all the time. to see to what lengths will he go in his drawings and his new names he calls for things without any references. But he gives no references half the time. But I love his, his characterization of most of the effects of treatment, definitely. But let me try to, please.
Yes, it's very refreshing to listen to your talk because we are accustomed to have lots of data, slides, and you really courageously to this audience say what you want to say. I'm very impressed. The honesty, that is very important in science. And while you are talking, for me, remind me of my first lesson in London, studying human genetics. And the professor came and to say, if you are studying genetics, I tell you, you have to study environment. There is no environment gene is not going to manifest. So I spent a lot of money, went to London, and this guy telling me from psychoanalytical situation, learning, then go there to study genetics, and he said, you should study environment. Now the more I listen to you, I feel that we are currently pursuing for biomarkers. That is not enough. We have to pursue psychosocial markers in developing the condition. If you don't like the illness, develop the condition. So what this professor impressed me is saying that the genetic, once you study them, it is easier to understand environment. If not the genetic anchor, environment is so amorphous, it's difficult to study them. So my PhD thesis was in genetic epidemiology, looking into from various multi-factors to look into what the genetics contribute to the condition and what the various environment actually contribute to the condition. That is today's inspire me to rethink what we are doing. It's very, very important. Thank you for giving me the insight to don't accept everything the dogma, always looking for what actually works. That is very important to me. Thank you.
I'm a little speechless with this appreciation. Thank you very much for this. I hope it's on camera. Let me try. I know there's questions, but I think I should wrap up something and leave on, because there's a second piece to this, which is so what do we do, really? But first of all, I do want to say that I agree completely substantially with you when you talk about psychosocial markers, if you will, which to me include, they go from the atmosphere down below. Everything that we construct, the built environment is sometimes made as I don't know where that comes from, maybe social work, the built environment. Architecture, what we construct, and I mean social relations and institutions and family and interpersonal relations, that's the environment, not just the soil we walk on, the air we breathe, the water we drink. So I really totally, fully agree with your approach. I think we've been looking at those biomarkers, hopefully to look at these, to open up another area of interaction, but we need to maybe start from the other side and look at the environment, where genes can only, the only place where genes can express is the environment. So what is it we need to do? I have no idea, really. But professional relationships clearly have got to change and become much more democratic and less based on the expertise of whoever it is that thinks that they know something that the other person doesn't know. So I think that's a trend now, and I don't know where it's going. It's really been facilitated by the internet. That idea that people could now express their views in ways that were uncensored by professionals. It started with drug. People could produce their own drug reports. There are now absolutely amazing, detailed websites, and I've analyzed comments from users on Lexapro with comments from physicians writing on the web on Lexapro, things like this. I published some studies with colleagues and students on how those discourses differ, and they don't differ very much. They don't differ very much. But there's a wealth of information out there that people are beginning to put out there, and that actually rivals, if you're open to it, the dominant explanations and descriptions of effects that we thought physicians were expert in. But the construction of knowledge about drugs, just to speak of drugs, is way beyond the medical sphere. I mean, it's all over the place. There's no more, and I think prescription privileges and all that stuff is eventually going to follow. All of that, the deconstruction of that is next, not next year, or maybe even next 20 years, but definitely the, if you will, this sort of democratic access to both knowledge and the products themselves is only going to increase. And it's been facilitated also by advertising, which has just made it into another, like a consumer product, like a watch or so. Because it's advertised daily, Vilify and what have you. So all of that is a huge change that's coming. And the role of the professional, in my view, has to completely adapt or lead or change with that. You are a resource person with a certain knowledge based on your experience, your studies, and you want to make yourself useful but dispensable to the person. In my view, that's the next step for proper professional relationships in mental health across the board. That's the next big step. The coercion issue, that's a long one. That's a major issue. It's unclear to me that coercion goes hand in hand with help. I really believe that they need to be separated. I think that it is inhumane to ask a single professional group or the same person to at once coerce and assess dangerousness and then administer people in institutions designed by that same person and so forth, and also say, let me give you a helping hand and so forth. I think that those functions really must be separated. I believe in the coercive function in a social system. Social systems need coercion, but as a last measure. As a last ultimate measure. I don't know if, for example, I think if we can keep in your professional role, or the increasing professional role of social workers and psychologists who also help and coerce at the same time, I don't think we should keep them in the same person. It makes no sense to me. I don't think it helps either coercion or help. And so this is something that I feel really has to be looked at straight on. Calling coercion not a treatment, but coercion, and wondering what it is about healing and helping, and what are the ethics of help, which is not the same as ethics of saving. The ethics of helping. What is it about that suffers when we have these dual mandates embodied in the same person in the same few minutes, we shift from one to the other. So that issue, and what tells me that is that, again, we're on a way where a lot of people are in jails that should not be, and a lot of people who are not in jails are coerced as if they were prisoners with less rights. So that's another issue. In other words, I'm not saying we're bad people who do this. I'm saying it ruins and hurts the essence of what we're supposed to be doing, I believe. And so that's it for now. I really want to thank you very much. I'm happy to discuss with anything. I just thank you very much for this opportunity. It didn't take much courage, just insouciance, as we say, recklessness to do this. But I truly appreciate the opportunity granted to me and the invitation from your department, your chair, from Nico and some residents. So to be here, thank you so much.
I just want to, again, thank Professor Cohen very much for being both provocative and thought-provoking in our grand rounds today. I consider it really wonderful that the first two major speakers who come to our department here have been Tom Insel and yourself, each of whom have presented challenges to our thinking. This is what a learning environment is about. We might not agree with Insel, we might not agree with you, but we need to be thinking about our assumptions and so thank you.
Thank you very much. It speaks very highly of your department to welcome speakers like that, to challenge some basic fundamental ideas. I
Right.
really think
Well,
it's very high.
thank you so much.